of telehealth. What we see is a variety of telehealth perspectives with the healthcare organizations that we work with. For some, this is just a stopgap, like just until this emergency is over, which, the public health emergency, maybe it ends on January 20th, but I think we all know that things are not going to be back to normal anytime soon, and, possibly not even before the end of 2021. So we also have other practices that embrace it, and their telehealth perspective is, wow, this is awesome. This is enhances access. It's a great modality for delivering services. Let's just add this to our toolbox of how better to serve our patients. We are offering CME for this webinar. It's 1 hour of CME. Details on how you can claim your CME will follow, but just to tell you for absolute sure and certain, none of us on the call that are participating as faculty, speakers, or planning, we all have no relevant financial relationships to disclose. Today, we're really hoping that we spark some conversation and ideas about how to enhance remote service delivery and reimbursement. And so we've done a lot of work to put together codes, billing codes, and some descriptions, and we've gone the extra step to put together what the reimbursement is. So if you look at a telehealth or a remote service delivery option, everyone wants to know, well, what's it going to mean to our bottom line? So as best we can, we've put this information together for you. Please know that even though I'm a clinician, I've managed a primary care clinic for 5 years, I'm not a billing expert. So, take all of this as a place to start, and just make sure that you confirm with your biller or your coder, or, go to your CPT book to make sure that we have it right if you decide to implement something. And we really want to clarify any gaps that you might have around billing and reimbursement. So, for example, a lot of practices are now looking at the chronic care management codes and principal care management codes, which have been around for a long, long time. But now the rubber is meeting the road for our using this as a way to enhance service delivery and do it remotely to keep everybody safe. And we'll talk just a little bit at the end about how to make it easier for patients to understand the billing side. Patients don't understand why we charge them, for example, for telehealth services. Why are you charging me the same as if I were to see you? You're just talking to me on the phone, or we're on a FaceTime call. Like, how can this possibly, be costing me this amount out of pocket? So we'll touch on that a little bit. Just a word about terminology. When we talk about telehealth, it's a broad and encompassing term. So technically, it includes the delivery of healthcare education to healthcare professionals, for example. It covers sharing. So, for example, if you have telestroke and you have a stroke expert and they are kind of Zoomed in or Skyped in to the hospital, that's telehealth. But telehealth, when we talk about billing and reimbursement, is defined by a very specific set of codes. And I think that a lot of our work on telehealth is clarifying what do we mean by telehealth, because there's a technical definition, which is very broad, and there's a practical definition. And I was really intrigued when I was reading the calendar year 2021 physician fee schedule final rule, that this tension about a telehealth technical definition and a telehealth practical definition that's defined by billing codes, operational pieces, and reimbursement, they sense this tension. And there's a quote, they refer to telehealth as a discrete set of services, all of which must ordinarily be furnished in person when they are instead furnished using interactive real-time telecommunication technology. And we're not going to go into that and take very much time, but just suffice it to say that when people say telehealth, they could mean two different things. So telehealth, that practical definition, the discrete set of services plus additional services falls under telemedicine. There's a whole set of virtual services that we'll cover today. So if we talk about the originating site or the distant site, just know originating site is that's where the patient is. Distant site is where the clinician is or the provider of the telehealth service. People throw around the term synchronous and asynchronous. Synchronous, that's what we're doing now. We're communicating in real time. Asynchronous, that's like email. So, somebody provides information and then another person reads it, consumes it, or evaluates it at a later date. There's a really great definition. So if anyone wants a takeaway definition from this webinar, the HRSA definition of telehealth is the technical definition of telehealth, and it is the one that I see most often cited. I see in other people's webinars. It's a good takeaway one to have going forward when you take forward information about telehealth. So there's this broad telehealth umbrella. Telemedicine is under telehealth, and then in telemedicine, we think about telehealth, that discrete set of services, and other virtual services. So there are a lot of telemedicine options, the telehealth, discrete set of services, the telephone E&M codes that are only going to be available during a public health emergency, the 2 options for virtual communication services, e-visits, which honestly, I don't see a lot of people taking advantage of. I think it's a great opportunity, but it's online, and a lot of our patients already struggle with the online component of healthcare service delivery. Remote physiologic monitoring, which is the one remote service delivery that has been shown to cut down on costs, particularly through reduced admissions, readmissions, and emergency department visits. Chronic and principal care management, really underutilized. The behavioral health and co-management codes as well, and interprofessional consultation. So let's see, we have about 16 people on the call. I know at least 4 of us are faculty and or planning. So let's launch a poll and take 3, let's just launch the poll. I think it's self-explanatory. So choose the top 3 remote service delivery options you'd like to learn more about today. If you provide us this feedback, I can take a deeper dive into the things that you're most interested in, and I can skim over some of the remote service delivery options that there's less interest in. So help me out. Let me know what you're most interested in. Is it the telehealth services, that discrete set of services, telephone E&M codes, digging more into remote physiologic or patient monitoring? What are you most interested in? I'm going to give you all about another 20 seconds to make up your mind and speak your mind. About 10 seconds more. Looks like. All right, so that's a minute. That's enough. And so, can you see the polling results, everyone? Okay, great. So it looks like there's the virtual communication services, so the virtual check-ins and remote evaluation of information is pretty popular. Telephone E&M, telehealth services, less interest in e-visits. Yeah, I'm quite fine to skim over those. Remote patient monitoring, a little more interest. Less interest in chronic and principal care management. I think this is a huge missed opportunity. We'll take a little bit of a dive into it, and then if you want to learn more, you can certainly contact us. And then the behavioral health piece. Less interest in interprofessional consultation, I'm not surprised. So that's helpful. Thank you so much. All right, let's sally forth now that we have some marching orders. So telehealth is defined by that discrete set of services. And there's a link to that list, and I check that list all the time. And the last time I checked it was probably about 2 weeks ago, and there were 248 codes. And I checked it in preparation for this webinar, and guess what? There's now 250 codes, and we are going to cover those 2 codes that were added. Those 2 codes were added in the calendar year 2021 Physician Fee Schedule Final Rule. Henceforth, I will only refer to it as the final rule because it's a bit of a mouthful, but there are now 250 codes that are that discrete set of telehealth services. These services have the requirement of a kind of knowing what a distant site and the originating site is. So the originating site is where the patient is, the distant site is where the practitioner is. Ordinarily, outside of a public health emergency, we have geographic restrictions about who can receive telehealth services, and it's based basically on whether you are in a rural area or not. They call it a metropolitan statistical area, and you're in a health professional shortage area. Thankfully, those restrictions are lifted, and there is legislation in the works to make sure that those geographic restrictions are permanently lifted, but it does require an act of Congress, literally. And then for the telehealth services, audio and video are required by Medicare. Each state Medicaid has different requirements. In the state of Idaho, for example, you must have audio and video, and if you're doing a telehealth visit and your video gets glitchy, you're not allowed to code a telehealth visit. In other areas, other states, the state Medicaid says, hey, it's up to the clinician to decide whether video is going to be required if the patient can't do it, and we have to do it audio only. That's what we're going to do. But Medicare does require audio and video, except during the public health emergency. And if you go to that discrete set of services, CMS lets you know which ones they allow to be provided without the video portion. Interestingly to me, and I guess it makes kind of sense, all of the evaluation and management codes, so your level 1, 2, 3, 4, and 5, new and established, do have the requirement for both audio and visual. Reimbursement is the same as for an in-person visit for Medicare. Most of our state Medicaid agencies do have parity, so they do pay the same as in-person visits. I do know that a lot of the private insurers are not going to be adhering to kind of good faith and reimbursing at parity, unfortunately. Our FQHCs and RHCs, they get reimbursed a flat rate. So they get reimbursed $92.03 during the public health emergency. There is legislation in the works to allow FQHCs and RHCs to deliver telehealth services. That reimbursement is going to be based on the prospective payment system. So I'm just really curious what that's going to look like. But I really have my fingers crossed for FQHCs and RHCs to continue providing telehealth services, because honestly, of all our primary care practices, it's our FQHCs and RHCs that need that allowance. All right, so there's an awesome resource. So the NRTRC covers 7 states. So what's the case in your state? Like what's what around telehealth? And that awesome resource, Sarah's going to paste the link to it. I use it all of the time. And what's really cool about that resource, also from the Telehealth Resource Center group, is that you can link exactly to the Medicaid statute. And it's like, I don't know how long it would take me to do all that research. And it's right there. Someone has done the work for you. It's just amazing. So Dr. Woolsey shared with me that there is a practice in Utah that has an awesome cheat sheet, and we don't have permission to share, it's a little proprietary, but they have a cheat sheet. And I think that every practice needs to have a cheat sheet of the remote services that they deliver, what insurance will cover it, what insurance won't cover it. So for example, in some states, remote patient monitoring is covered by the state Medicaid agency. In other states, it's not. For example, in Idaho, remote patient monitoring is not covered by Idaho Medicaid. In Louisiana, they cover remote patient monitoring, but they call it something else. So what's the case in your state? That awesome resource that I just mentioned, that's how you find out. You'll find that at that link that Dr. Woolsey posted. But if you're in behavioral health, or you're in primary care, or you are in a specialty, or you're a hospital, like, what are your telehealth options? What insurer covers it? What CPT code do you need? What modifier do you need? What's the reimbursement? What's the copay, coinsurance, or deductible that the patient is going to have to pay? And or is it waived? And is there an end to telehealth coverage for whatever code is that you're talking about? And just a little note on the right-hand side are those telemedicine options. So all of those options, should you think about having those on your list. So know which payers reimburse for which telemedicine options. Make it easy to bill correctly using a cheat sheet. Clinicians, often they just see whoever's in their schedule. They don't know, am I doing a telehealth visit, or, you know, is this an e-visit, or a telephone E&M code? Like, those details, we often just play ignorance and kind of toss our head and go, yeah, I don't know. You know, I'm just taking care of patients. And so there is this opportunity to kind of make it easy and help get your clinicians and care team members and billers and coders up to speed on what your options are with delivering remote services. You may have to modify or standardize workflows. I've worked with some healthcare organizations where I've asked, you know, what are you doing with telehealth? And the IT folks have told me, well, some people have asked for Zoom URLs, but really that's all we're doing. Like, you want a standard way for people to be doing this to keep patients safe. So if you have quality issues from provider to provider, or you don't have standard workflows, it puts your patients at risk. So if you're doing telehealth visits, but you're not doing pre-visit planning anymore, and so you're not identifying and addressing gaps in care, there is a danger for missed and delayed diagnoses, which is terrible for patients, but also happens to be the #1 reason for malpractice suits. So training is definitely in order, and the NRTRC is working with the University of Washington to develop training opportunities, so stay tuned for more of that. And as we go forward, you're going to see that our slides have the prices or the cost or the national payment amount from CMS for certain CPT codes. It's really, really easy for you to do this yourself. So if you go to that link and you click accept, I've put what the fields are that you'll need to change. So you'll need to change to the specific locality. You'll have to put in your HCPCS code, and then you have to choose your MAC locality. And for all of us, for all of our 7 states, I think there's only one locality. It covers the entire state because we're kind of rural states. The state of Washington, for example, they have 2 localities, but it's pretty easy for us. And you'll see that I looked up the transitional care management code, which can be delivered by telehealth, and I looked it up for Alaska. And the reimbursement for that particular code for transitional care management, when you see a patient within 7 days of discharge from the inpatient setting, it's a whopping $316. And I wonder how many practices are keeping track of their patients who are discharged from the hospital and immediately making that outreach call to set up a telehealth appointment to do transitional care management. This is a really important service that we can deliver to our patients. It's highly underutilized in the 2020 final rule. CMS acknowledged that it's underutilized, and to increase utilization, they lifted some of the co-billing requirements and they upped the reimbursement. I will say that this is Alaska, and that reimbursement of almost $317 in Alaska is higher than some other states. But I liked to choose that example from Alaska because that is a hefty reimbursement. And if you don't know, and now with COVID, especially with it just spiraling out of control, we need to know when our patients are in the hospital, and we need to provide kind of that transition to home. And this is a good way to support our patients and get paid for it. So, you know, that final rule they will publish it officially. So you can find it, it's online, but it's not in the format that they will publish it in on December 28th. So right now it's 1,994 pages. It's a lot. So, you know, what is good to know from the final rule? There are some allowances. Services may be furnished and billed when provided incident to distant site physicians. So the telehealth codes are usually only going to be able to be used by clinicians who can bill E&M codes. This opens up to, if you're doing, for example, transitional care management by telehealth, if you have a care team member, a nurse, or an MA to do a portion of the visit, this is incident 2. And so, you know, it really takes a team. And honestly, sometimes our nurses are better than our clinicians about doing transitional care management, doing medication reconciliation, making sure that that the home is safe, that they're having any durable medical equipment that they need, like a walker. In the final rule, CMS is allowing direct supervision to be provided using basically telehealth, using real-time interactive audio. So previously, the supervision had to be on site. So they're extending that, and it's only interim. So, you know, for now, it can be really useful. And then there were a lot of questions about whether you could use telehealth to keep patients safe. So if you had like a room at your clinic and you could put the patient there and maybe the clinician was at home, could you do, or they were in the, sorry, bad example. So the patient was in the exam room, but the clinician was in their office at the clinic. Could we do telehealth and bill for telehealth? And CMS clarified in this final rule that no, that's not, you can't do that. So just to let you know that ongoing with the rest of these slides, the prices are the national payment amount. So I didn't use the Alaska amount. I didn't use the Idaho amount. I didn't use the Utah amount. I used the kind of the national, which is kind of average. And your state may be a little higher if you're at Alaska, a little lower if you're Utah or Idaho. But just to say, that's what we're using in our slides. And you know, don't take this to the bank. You know, really have your biller or coder take a look. So, you know how I said that whatever specialty you're in, so whether it's primary care or neurology or behavioral health, identify what the telehealth codes are that you're going to use and know what the reimbursement is. So this is an example of, if you were in primary care, what you could do. Like what, in that 250 codes, like what's the select set of codes that we can use to enhance access, serve our patients, and capture revenue. So, you know, there's the E&M codes, the 99201, 99211. Oh, by the way, did you notice that 99201 is missing from my table? In this final rule, CMS is dropping 99201, just FYI. Thank you, Sarah. And they actually have a really nice discussion about why they're doing it. But you know, we just want a little less complication. So your E&M visits, you know, unless there's a compelling reason why you need to see somebody in person, you should be doing all of your E&M and have an algorithm so that you're seeing patients safely in person and seeing patients that don't need to be seen in person by telehealth. And so many primary care practices already have policies and procedure in place. Like if somebody's having excruciating abdominal pain, you know, I need to do a physical exam and it is just not going to work by telehealth. I need to see them. So having some protocol around who you see virtually and who you see in person is really important. Now that we have so many people coming down with COVID-19, advanced care planning can be done by telehealth, and it's really important to get this done. So somebody may be a do not resuscitate, do not intubate, or as we call them, a DNR, DNI. However, what happens if they need to go on a ventilator? They might want to say, I may be DNR, DNI, but I do want to be put on a ventilator. Now is the time to get advanced care planning in place and to review advanced care planning for people who have done advanced care planning but may want to adjust their advanced directives. if I were a primary care clinic, I would start going through my panel of patients, and I would do outreach to everybody 65 and older who most likely also has Medicare. And I would do proactive outreach to do advanced care planning by telehealth. Oh, by the way, if you do advanced care planning, the video portion is not required. And this is a huge and important patient service. Here at CoMagine Health, we're passionate about and just adamant about the importance of advanced care planning. The reimbursement is decent. Look at that, $87 and then $76 for additional time. So that 99498 code is an add-on code if you end up spending extra time with your patient. Transitional care management, we already touched on it. The reimbursement is great. So you can see that the national reimbursement rate is $248, and Alaska was what, $317. So they have enhanced reimbursement in Alaska for a good reason. There's no reason we can't do the welcome to Medicare visit and annual wellness visits. CoMagine Health has an implementation guide around the annual wellness visit. Again, I would be running reports on all of my patients who are due for their annual wellness visit, and I would start doing that by telehealth, not only because they need that annual wellness visit, but because I want to talk to them. I want to make sure, are they okay? And this is also an opportunity to do advanced care planning. So you can do kind of 2 in 1 and really serve your patients. And if you're looking for revenue, or you have staff that are otherwise assigned that would have the time to do this, or you now have space in your schedule because people are not coming in to see you, this is the time to do this type of work. MNT, medical nutrition therapy, both individual and group. There are some challenges with group, but this is the time. I mean, people need this more than ever. We have COVID-19 and people are talking about the COVID-20. 20 pounds, gaining 20 pounds because people are not as active, they're stressed, they're comfort eating. And so you can only do MNT for certain patients, but DSMT and group patient group and individual education for patients with chronic kidney disease. Counseling for lung cancer. So across the United States, we are abysmal at doing appropriate lung cancer screening. I think the rate is right around 5%. So we're screening about 5% of our target population. This might be the time to bone up on what the screening recommendations are, identify who those patients are who should be screened, and start talking about doing screening using a CT scan. That's a very hefty discussion, and the reimbursement is terrible at only $30 for a really important discussion. And people are not going to be getting CT scans until the end of the PHE, but you can start engaging in those discussions and make a plan for when you don't have to delay treatment. Treatment for opioid use disorder, these are really important. And I think anybody in the field of substance use disorder is already aware of these. The reimbursement is really great. It's really important work. And I'm going to go to one more slide, and then I'm going to pause for a second to hear whether we have input from our faculty on the phone, all of whom have a tremendous amount of experience in telehealth and in these topics that I'm discussing. So this is new. You heard it here. If you have not read the 1,994 pages, you would have no idea about this information, and the NRTRC is bringing it to you today. And I really worry, there's so much great information in those final rules, and unless CMS publishes it or has an MLN booklet or fact sheet, I'm like, how is the word going to get out? But it's really, really cool that CMS has added these codes. So these are add-on codes. So if you have a patient that has complexity, you're going to use that G2211. And oh, by the way, if you look up the price or cost for it, they're not in there yet. So CMS usually updates that tool every quarter. So I expect January 1, we can put these codes in and see what the reimbursement is going to be. I do want to say that I think that these codes are groundbreaking for clinicians. So CMS says that, and I'm going to read a quote from the final rule. So for example, in the context of primary care, the add-on code G211 could recognize the resources inherent in holistic patient-centered care that integrates the treatment of illness or injury, management of acute and chronic health conditions, and coordination of specialty care in a collaborative relationship with the clinical care team. Finally, we believe that the G211 could bolster the efforts of practitioners in rural communities, including non-physician practitioners, to deliver the comprehensive and longitudinal care that the code G2211 describes. So anyone in healthcare, we pull our hair out, we don't have enough time with patients. We don't have enough time with patients. Like every 15 minutes, we have to see another patient because we're still in a fee-for-service world. This code gives us the option for every 15 minutes beyond an E&M code, because the E&M codes are described by time. We're going to see more emphasis on that in 2021. This is CMS saying, we know you need more time with your patients, and we have this code to reimburse you for that person-centered care. And I'm sorry, I lied. There's actually one more slide. And so there are some other telehealth opportunities for primary care. The reimbursement is not that good. If you're an FQHC or RHC right now, you're still getting reimbursed 9203 for whatever telehealth code you use. The reimbursement for these are low, but a lot of our practices are collecting quality data. So what percent of your patients have you addressed smoking use and cessation counseling? So if you do that, yeah, maybe it's a tiny little reimbursement, but each of these have associated codes and reimbursements that are small, but you can get paid for some of that work. So I really want to pause now to see whether our faculty on the line have additional comments to add to what we've covered so far.
Tracy, just a couple things to think about as, again, the world continues to change, but there will be times when providers, because of quarantine reasons, will work from home. And if they're feeling well, and aren't seeing their regular panels of patients, there are maybe some, potential non-urgent outreaches, such as the annual wellness visit. So, be thinking about your workforce, what they're able to do, what they can't do, as you're looking at these telecodes and seeing if there are opportunities for them. So that's one comment. And then you're going to talk about copays at the end. I think it's just important to as we're doing this work, to be aware of how it may come across to our patients. Thanks, Tracy.
All right. Thank you. Anyone else? Comments? Telephone evaluation and management, there was fair interest in this. So these are a set of codes that have been implemented by CMS just for the public health emergency. And there are codes that can be used for clinicians who can bill E&M. And then there are portions of the care that are termed assessment and management. So if you're, for example, a social worker, you don't do evaluation and management, but you do assessment and management. Same with an RN. The reimbursement is pretty good for FQHCs and RHCs. They get reimbursed the same, $92.03 for telephone evaluation and management as they do for a telehealth code. And what we're seeing is that in those cases, our FQHCs and RHCs are really just doing the telephone evaluation and management because it's easier for their patients. I'm working with a practice that was doing telephone evaluation and management, so they are a health center, and their no-show rate was 2%. So then they shifted to, let's call it real telehealth, and their no-show rate bumped up to 50%. So this is really great. We should be taking advantage of it. It's patient-centric. There's decent reimbursement for it as well. And these codes are listed on that massive 250 code list, but they are listed as temporary for the public health emergency only. The virtual communication services, there was some interest in this as well. These came on the scene and starting in 2019. I was all excited about them. I told everybody about them, like, oh my gosh, you know, we've got this virtual check-in. This is awesome. And when I told them that the reimbursement was about $14, they were like, meh, not going to do it. So CMS has increased the reimbursement to about $25. And I still am not seeing a lot of people using this. CMS really thinks that, you know, these sets of codes are really about preventing office visits. So what they're hoping is that if clinicians take up these virtual communication services, we'll have less office visits, patients will be served, will reduce cost. But, you know, I think that when they look at the data, they are going to, they're going to see that, you know, they do that. They kind of put out a price and then they see whether people take it up. And when the price is too low, people do not take it up. So I think we're going to see either they're going to get rid of these codes, supplant them with something else. I'm not quite sure what's going to happen. These also have to be initiated by patients. So there are ways around that. So if somebody calls and they say, well, I'm not sure if I need a visitor or not, you can use your verbiage and say, well, we do have this option, but it has to be requested by you. You know, we could do this kind of virtual check in just a couple minutes. The remote evaluation of recorded video or images is really, really cool. I'm Dr. Mom. I'm a physician assistant. I'm not a doctor, but my daughter calls me Dr. Mom, and she'll send me images all the time. Hey, Mom, Mason slammed his finger in the sliding glass door. Do I need to go get this checked out? So-and-so cut their lip. Is this okay? Someone has this funny lesion on their foot. That I don't get paid $25 for each one of those, but clinicians can. So this is a little underutilized, but you know, the reimbursement I think is probably what's keeping people from using this a little more. And for anything in blue font, it comes from the final rule. So there's a new code 2250. It's going to be the same as 2010, which is, you know, a really poor reimbursement, but traditionally, like the 2010 is a provider specific code. And then if they have kind of ancillary staff, a similar code to have ancillary staff provide the services, they even decrease the reimbursement lower. And I think because the reimbursement for 2010 is already so low, it's going to be the same. And it's going to be at around probably $12 to $14 reimbursement. But this kind of allows ancillary staff to be part of virtual communication services. And then the other piece of virtual communication services with these set of codes is this virtual check-in piece. And because the telephone E&M codes are going to go away after the public health emergency, CMS, trying to accommodate that, has, we now have this new code called G2252, and it's more than just a virtual check-in. It's supposed to be 11 to 20 minutes, and it maps to a 99442 code, which, you know, probably is true but useless information in this case. And it also has that concurrent ancillary staff code, which I think is going to be great. So e-visits, not much interest in this, so I'm going to just skip over this. Everyone will receive the slides, of course, and so you can refer to this information. I think the thing that's most important is that CMS is changing the code. You can see in the blue font, they're changing it from a G code to a CPT code. Remote physiologic monitoring. There was not a lot of interest in remote physiologic monitoring on our poll today. I think it's amazing. I think everybody should be doing it. But I will respect the guidance from our participants. We will send this resource out to you. This is information, this table that we're going to send out. So it's a set of several tables. You will not find this compilation of information unless you actually read the proposed and final rules for the past 3 years. So this is very unique information. So remote physiologic monitoring, you can see what the codes are. You set up, so this cannot be patient reported data. So if you have kind of Bluetooth enabled and you know, the pulse oximetry is getting sent to the clinician, it's not the patient kind of sending you their blood pressure log. There is a fair amount of reimbursement to be captured here. There are a lot of conditions which we've added to this table. So I'm just going to slowly scroll past remote physiologic monitoring. I just want to make the case that this has the most data behind it for improving patient outcomes and reducing costs. And yeah, sure, readmissions, emergency department visits, and admissions promote healthcare costs, but guess who it's really terrible for? Patients. They don't like going back to the hospital, so let's do what we can to keep them out. There was also minimal interest in chronic care management and principal care management. We do have a resource and implementation guide around chronic care management and principal care management. This is, whether you like chronic care management or not, this is the wave of the future. 5% of healthcare, 5% of our high-risk patients account for 50% of healthcare costs, and it's only a matter of time before healthcare insurers and CMS make us identify our highest risk patients and provide enhanced services to them to lower costs, mostly around admissions, readmissions, and emergency department visits. So this is coming, and I feel like I want everybody to get on board. I've been pushing chronic care management since it came on the scene. It's really hard to get up and running on this. This is a webinar in and of itself. If you want our resource for implementing these or want to talk to us about it, just type into chat and we'll capture that you have that interest. The behavioral health integration is like chronic care management, just with a behavioral health spin on it. There is one code that you can use for behavioral health integration. So you can see this general code down here, the 99484 general behavioral health integration. So most practices can use that code. The co-CM, so the Psychiatric Collaborative Care Services, does require a psychiatrist, or a psychiatric consultant. So this is not available to all practices, but it is really great for expanding behavioral health access, which we know is a problem in all of our 7 states. Patients are waiting months and months and months to get in, and it's really just, it's a crisis. So I'm going to close this. Does anyone, before I close it, are there any questions on the line about any of these remote service delivery options?
Feel free to unmute yourself and or put something in chat, and I'd be happy to read it out to Tracy. Trudy.
I answer to anything. It's okay. So we touched on remote physiologic monitoring or patient monitoring. I think I've made the case. Chronic and principal care management was really exciting about 2021. If we have anybody who is with a federally qualified health center or a rural health clinic, starting in 2021, CMS is going to allow them to provide the services and bill for principal care management, which is huge. So rather than having two or more chronic conditions to deliver the chronic care management services, if somebody has a one acute issue and they are a Medicare patient, you can deliver principal care management. And I think this is a huge opportunity to deliver enhanced services and capture reimbursement. I really wish more people would take advantage of this option. We talked about behavioral health. Interprofessional consultation, I don't see a lot of practices using this. I wish that we had like an implementation guide to get out. I do know that my own PCP needed to get approval for me for a medication, so he needed to talk to a neurologist. I know TMI, but he actually used this code. I talked to him about it, and so we have a shortage of neurologists here in Pocatello, Idaho, and so he actually used that code, the 99452, which is for the requesting physician. So, I feel like there's this opportunity here for identifying which of your specialists to whom you refer are aware of these codes and are using them, and figure out on both sides, how can we use this to keep our patients safe, save time for you and us and them, and just be efficient. I feel as though this is an area that is underutilized as well. So that concludes kind of our billing and reimbursement piece. So you may recall that one of our objectives was thinking about the person-centered side of telehealth billing. So I'm just going to take a few minutes to cover that piece. Things are different. We delivered an echo session yesterday for the University of Utah College of Nursing, and we had an amazing nurse practitioner on who talked about the challenges of billing and collecting copay. So she really didn't have to make many calls to get that copay collected, you know, maybe 10 calls a month or so, and now that's up to 40 per month. So, and if you have a telehealth visit with your clinician and you ask, you know, how much is this going to cost me? You'll get that kind of shake of the head, like, I don't know. You know, and how do I pay my copay? So I can't actually hand you my credit card anymore. Like, what's the easiest way for patients to do that? Part of your telehealth visit, do you have worked into the workflow that, you know, at the end of your visit, I'll have you talk to our reception staff and they'll take your credit card information over the phone or something. Like how, like there's this missing link here that I don't think we've thought about. Patients don't understand, why am I going to pay you the same for this kind of, I'm talking to you on the phone kind of like, or we're doing FaceTime, like, why am I paying you when the same amount for when I come in person? And patients may not know that. What they are going to know is their payment out of pocket. So they don't know like what code that you're going to bill in 99213 and it's, you know, reimburses for X amount. But all they care about is out of pocket. So they don't care whether you bill the same or not, but what they feel and what they see is, I'm paying the same copay. Why is that? Like, why is this not free? Like, you're just talking to me. So, you know, acknowledge that that's the case. And there are some expectations that you can set up front, including ensuring that when patients schedule a televisit, that they have the expectation you can't be multitasking. This is just like an in-person visit. Like, we shouldn't have you having a visit with me while you're grocery shopping or, you know, watching TV or, you know, scrolling online or checking your texts. And be transparent. So we have huge opportunities in whatever field of medicine we are to be transparent about how much we charge patients for the services that we deliver. It is I can go down a rabbit hole, I will spare you. I'm just saying, let's be transparent about cost to our patients. Know before the visit what the patient's payments are going to be. If they're Medicaid, Medicare, if they're Blue Cross. During the public health emergency, we can waive copays and deductibles for some patients. We need to know ahead of time so we can tell patients what the case is, especially because our patients are even more financially strapped. So know in advance if you possibly can. So when that question comes up, you don't just have to shake your head and play dumb. So, you know, we can do better. We can do better. And make it easy for them to pay those deductibles and copays. So when we heard from Danielle yesterday, you know, she asked everybody on the echo session, like, what are your ideas? And people had great ideas, like, how do you get those copays done? Some require early check-in for the telehealth visit, and they're collecting the copays at that time. And know what the requirements are for your state Medicaid agency. So in Utah, for example, you know, if for Medicare, the consent for telehealth is pretty easy. Basically, just tell them it's a telehealth visit and you are going to be responsible for copays. But each state is very different in the informed consent that they have to collect. The state of Utah, for example, is immense. It's like so complicated. I wonder if anybody's doing it. Same with the state of Idaho. I haven't checked out our other 5 states. But you know, at that awesome resource that I mentioned, I was able to go to the National Consortium of Telehealth Resource Centers, and I was able to click on that awesome resource. I was able to just take a deep dive down and look at, you know, for Utah, you know, what is it? And part of informed consent, if you're going to be doing telehealth, you have to tell the patient, you know, the additional fees for telehealth services, if any, and how the payment is to be made for those additional fees. You know, I think a lot of people just don't know that that's a requirement. A lot of information, talking fast, a lot of content, heavy slides. We have 5 more minutes, and we are going to open that up for questions and discussion. What questions do you have?
So Trudy, Melanie Glaze had a question in chat to clarify 99452 is for the requesting physician, not the specialist. And I believe that was on slide 23 right before questions. And I believe that would be the specialist would be reimbursed. That's the correct interpretation. So I'll go ahead and put that in chat for you, Melanie. But as Trudy said, these slides will be sent out to all the attendees.
Right. Right. And we can scroll back to that slide as well. You said 99452?
Correct.
Yep. Yep. So that is for the treating or requesting physician. So if it's you who's making the referral. So if you look at the other ones, 946 through 449, it's the patient's treating, right. So I'm in the middle of a webinar, and then I'm going to let you answer that so so that I don't struggle over it. But yes, you will have the slides, and I'm just afraid I'm going to say the wrong thing, and I know that you'll be right on. So Melanie, I'm curious, are you thinking about using or implementing these codes?
Well, right after this, we have a billing meeting here at Legacy about telehealth. And so you were mentioning that not a lot of people know about this one. So I just want to kind of throw it out and see if people know. So. Thank you.
Great, great. So do you want the slides for your meeting?
I would love them. But we meet again in 2 weeks, so it's fine.
Okay.
I'll wait till they come through.
Okay.
Thank you.
All right. I was going to take down your email address, and we were going to shoot them out to you 5 minutes after the close of the webinar, if you want them.
So if there are no more questions, we have about 3 minutes left that we'll give back your day. I just really want to thank Trudy and Dr. Woosley for this very timely, very informative, easy to follow presentation on something that is constantly changing and not that easy to follow. So much gratitude, and we will be sending these out. There'll also be a short survey if you wouldn't mind filling out for the NRTRC, just so we can make sure we're providing content that is of value to you. And everybody stay safe, have happy holidays. Our next office hours is January 6th, and that'll be more of a casual, open conversation hour. And then we also have another webinar that we're working with Comagine with on January 20th over the noon hour Mountain Standard Time on patient-facing telehealth interactions. So that is it. And yes, Rob, the slides are going to be made available. And I agree, it was a great presentation. So thanks, Trudy and Dr. Woosley and Comagine Health.
Thank you so much.